Bismillahirrahmanirrahim. I welcome again all the participants in the pathology sessions of 21st Annual Symposium. Today we have two sessions. In the first session, we have two lectures of Dr. Khalid Amin, who is based in Minneapolis, United States, where he is faculty in the University of Minnesota Medical School, Department of Laboratory Medicine and Pathology. His primary areas of expertise and practice are cytopathology and gastrointestinal pathology. That will be reflected in his two talks. Dr. Khalid is graduate of Rawalpindi Medical College. He started his histopathology training in AFIP under the mentorship and supervision of Dr. Sajid Mushtaq. And later he moved to US, where he did his pathology residency, followed by fellowship in cytopathology from University of Kansas Medical Center. Dr. Khalid has authored more than 70 publications in peer-reviewed journals. He is currently the section editor of ASCP cytology case reports. And today his two talks will be, first will be cytology of solid neoplastic and non-neoplastic lesions of pancreas with histological correlates. And second would be cytology of cystic neoplastic and non-neoplastic lesions of pancreas with histological correlates. Now over to Dr. Khalid.
So today in this two-part talk, I'm going to present a collection of interesting cystic and solid pancreatic neoplasms that we saw over the years in our practice. It includes rare entities with classical features and more common neoplasms with atypical features. I will start with illustration of cytological features of each case, followed by histology, which is either from a cell block preparation or a resection specimen. In the first part of my talk, I will present cases of solid pancreatic neoplasms. Our first case is a 65-year-old woman who was referred to us from an outside hospital where a EUS FNA was performed but did not reveal any definite evidence of malignancy. She had a history of breast and colon cancer and was evaluated for abdominal pain and jaundice. CT scan revealed a 3.4 centimeter suspicious appearing pancreatic head mass with upstream dilatation of the pancreatic duct. A repeat FNA was performed in our institution. This is a low power image of diff-quick stain smear of that mass, which as you can see is not very cellular and is composed of these singly scattered cells and small groups of cells that appear rather bland on this low magnification. This is the higher magnification, which shows the morphology of these lesional cells. And as you can see, it is characterized by a relatively abundant cytoplasm, which has these microvesicular foamy appearance. The nuclei are small and have little atypia. This is the Pap stain smear that, as you can see, shows some focal nuclear atypia. And this is the cell block, which shows some strips and groups of epithelial cells which have same morphology as I showed you in my last slide, having abundant cytoplasm, which has a little bit of foamy appearance. Overall, we were not fully convinced that we should call it malignant. However, we were worried. So we ended up calling this suspicious. But our clinical team, especially our oncologists, they would not initiate neoadjuvant chemotherapy unless and until they get a definitive diagnosis of malignancy. So it was decided that a repeat FNA should be performed. And this was the third FNA on this patient. The repeat FNA actually showed a little bit more, it was more cellular and showed lesional cells that had similar morphology to what we saw earlier. And as you can see over here, these cells are characterized by abundant microvesicular cytoplasm. The nuclei are small. In this Pap stain smear, you can see that there is some focal nuclear atypia characterized by anisonucleosis. However, one preparation that really helped us clinch the diagnosis in this case was actually the cell block, which showed these groups of cells with foamy cytoplasm and resinoid nuclei but it was the stromal elements that showed infiltration by these very abnormal glands with irregular contours. If you look at the cells lining these glands, they are not super malignant, but overall we felt that this is enough for us to call it a malignant neoplasm. So the patient underwent a Whipple's resection, and it showed a tumor that, as you can see over here, most of the tumor actually was composed of these very bland appearing glands that are lined by these cells, which has, again, what we saw in cytology, abundant foamy cytoplasm. The nuclei are small, some rhizoid, but a characteristic feature to note over here is basically the apical regions of these cells lining these glands, which show chromophilic condensation, imparting a brush border-like appearance to these glands. Similarly, we saw cells with similar morphology lining the ducts. In other areas of this tumor, as you can see in this slide, there were frankly malignant glands, which were lined by really pleomorphic cells where there was no doubt about the malignancy. And over here, you see perineural invasion, which is something that you can expect in most cases of ductal adenocarcinoma of the pancreas. So what I showed you actually was a case of pancreatic ductal adenocarcinoma with foamy gland pattern, which is a deceptively benign appearing and morphologically distinct pattern of ductal adenocarcinoma that is challenging to diagnose on cytology and histology. Isolated cases of this entity were first described in the 80s and 90s, but the most comprehensive study describing this entity was published by Adse et al. In 2000, which included 20 cases. 4 of the cases in that study were pure foamy gland variants, while the remaining 16 had ductal adenocarcinoma component. In their study, they also demonstrated the distinct staining pattern of these foamy glands with various histochemical stains. And as you can see here, the brush border-like zone of these foamy glands is staining very nicely positive with mucicarmine. It is also staining with Elchian blue compared to the benign mucinous ducts. Over here, this is high iron diamine, which also stains the brush border-like zone. And this positivity actually favors presence of sialated acidic mucin, which, by the way, is the most common mucin that has been shown in pancreatic ductal adenocarcinoma. A few years ago, we actually did a retrospective study to identify factors responsible for indefinitive diagnosis of on EUSFNA requiring repeat procedures. Although the repeat rate in our institution is fairly low, thanks to our outstanding gastroenterologists who are highly skilled in performing these procedures, nevertheless, we did identify 27 patients undergoing 56 procedures during this 5-year study period. Among various causes, of which operator experience was the leading cause, as you can see over here, seen in 12 of the 27 patients, we did identify 6 cases where challenging morphology led to indefinitive diagnosis, resulting in repeat procedure. Of the 6 cases, actually 4 cases exhibited extensive bland foamy gland changes that possibly led the cytologist to go with atypical and suspicious diagnosis, highlighting the diagnostic difficulty that can be encountered with this deceptively bland morphological variant of pancreatic ductal adenocarcinoma. Next, I'm going to present a pair of cases that highlights the morphological spectrum of various tumors that are included in this broad group. Our first case is actually a 59-year-old man with history of colon cancer and who was evaluated for abdominal pain and progressive difficulty in swallowing that led to the discovery of a pancreatic tail mass. This all happened at an outside hospital. On CT scan, a couple of things were identified. First, there was a pancreatic tail lesion, which was ill-defined, and there was a large 15-centimeter lesion adjacent to it, along with multiple enlarged mediastinal and retroperitoneal lymph nodes. Sampling via EUSFNA was performed of the pancreatic tail lesion, the lesion adjacent to it, and the lymph nodes. And this was done again at the outside hospital, and we received the specimen as a concert. And as you can see over here, this is a very cellular smear, diff-quick stained smear that is composed of actually discohesive cluster of cells. On high power, you can see that many of these cells have rather moderate amount of cytoplasm that is giving some cells plasmacytoid appearance. Over here, it showed another population of cells where you can see that the cytoplasmic features hints towards glandular differentiation. This is the PAP stain smears, and which highlights the nuclear morphology of these tumor cells, which is highlighted or characterized by presence of very prominent nucleoli. Another thing to note is the chromatin, which is showing this very finely granular characteristic, just like salt and pepper, indicating probably some neuroendocrine differentiation of these cells. This is the cell block, and as you can see, that it showed a solid tumor. By the way, in this case, no resection was performed because of the advanced nature of the disease. And over here, it shows a solid high-grade neoplasm. And if you look closer over here, you will find that there are some glandular elements which are very intimately associated with high-grade solid areas, indicating possibly a dual differentiation of this neoplasm. Again, as we already were suspicious of some neuroendocrine differentiation, we started with neuroendocrine markers. And as you can see over here, the tumor is very strongly and diffusely positive with cyanopropysin, while chromogranin showed only patchy positivity in small subset of cells. Again, in my first slide, I showed you some cell clusters that showed possible glandular differentiation, and we also saw some glandular structures in the cell block. Therefore, we did some additional stains. And interestingly, the significant portion of the tumor turned out to be positive for trypsin. And over here, this is a PES with diastase, and it showed scattered cells that are positive. To further characterize the neuroendocrine elements, we did a KICT7 stain, which, as you can see, is positive in more than 50% of the cells. So based on the morphological findings and the immunohistochemical profile, we ended up calling this tumor as a mixed neuroendocrine non-endocrine tumor, or a MINEN, where the non-neuroendocrine component is actually an acinar cell carcinoma. Next case, which is somewhat similar to the last one, is a 66-year-old woman who has a history of lung cancer and a profound weight loss of over 50 pounds, presenting with obstructive jaundice. On imaging, a 4.4 centimeter pancreatic mass was identified. Again, FNA was performed at an outside hospital, which was positive for malignancy. The patient received neoadjuvant chemotherapy with excellent response, and a Whipple resection was performed at our hospital. These are the cytological specimens that we received from that outside hospital. And as you can see, this is actually a cytospin preparation. It is quite cellular and shows mostly discohesive cells with high-grade features. But if you look admixed within these with these high-grade cells, you will see some cells that are exhibiting glandular features. Over here, you can see cytoplasmic vacuolations, and over here, this high-power image is showing glandular structure. This is the cell block that shows a high-grade tumor with focal glandular formations. Over here, you can see some glandular elements intimately associated with this solid high-grade appearing tumor, which is to some extent similar to what we saw in the last case. And the high-grade nature of this neoplasm can also be recognized by the fact that most of these cells have high NC ratio. There are you can identify individual cell necrosis, and also occasional mitosis can also be seen. Again, we started with neuroendocrine markers, and this tumor showed patchy positivity with both synaptophysin and CD56. On resection, it showed a high-grade, predominantly solid neoplasm, which is composed of solid, irregular nests and some trabeculae. On a high power, if you look at these nests, you will find two components. Over here, this is a component, solid component, which gives an appearance of a large cell neuroendocrine carcinoma. And over here, you can see clearly glandular component that is very intimately associated with high-grade solid component. So this tumor, as we already saw in the cytology specimens, it was most of the tumor showed positivity with synaptophysin, while chromogranin was positive in a small subset of cells. Due to the presence of some glandular elements, we further, we did more immunohistochemical stains and also histochemical stains. And as you can see over here, compared to the last case, this case turned out to be totally negative for trypsin. However, with mucicarmine, there were very nice areas indicating presence of mucin, as you can see over here. These are the glandular areas that are intimately associated with these high-grade solid areas. Ki67 again showed positivity in more than 50% of the cells, indicating the presence of a high-grade neuroendocrine component. So this is another example of myelin, or a mixed neuroendocrine non-endocrine tumor, where the non-neuroendocrine component actually was a ductal adenocarcinoma. So the term myelin was actually introduced in the new WHO classification of digestive tumor that came out in 2019. And in order to qualify for this diagnosis, each component have to account for at least 30% of the tumor. Typically, both components are high grade. And although we have seen only a few cases, but I will tell you from my experience is that most of the time, the non-neuroendocrine component is actually an acinar cell carcinoma. The high-grade component is usually large cell neuroendocrine carcinoma. And both these components can be distinct or they can be intermingled, as we saw in our two cases, where actually in both cases, the glandular components were intimately associated with the neuroendocrine component. One important thing about this tumor is that you have to do a Ki67 immunostain to actually characterize the neuroendocrine component. And the reason of that is because the biology of this disease is actually dictated by the neuroendocrine component. And it has been shown that this tumor, myelins, actually have better prognosis than a pure neuroendocrine carcinoma or a pure ductal adenocarcinoma or a pure acinar cell carcinoma. So our next case is actually a 90-year-old man who presented with worsening dysphagia. And on further workup, a pancreatic mass was revealed. On EUS, a 3.6 centimeter heterogeneous solid pancreatic tail mass was identified with poorly defined borders, and it was sampled. These are the low power images of the cytology smears. And as you can see that they are composed of irregular crowded groups that over here gives an appearance of like pseudo-acinar formations. And over here, some of them, they look like a bunch of grapes. On high power, you will see that this tumor is exhibiting a very characteristic feature, which is this presence of frothy background. This is actually caused by these very delicate tumor cells that rupture and expel their zymogen granules, giving this frothy background, which is very characteristic of this tumor. This is a Pap stain smear that highlights the nuclear morphology, which is characterized by coarse chromatin and prominent nucleoli. The nuclear atypia is at the most moderate. This is the cell block where it shows a tumor that is composed of very back-to-back glands in a microglandular arrangement, or here you can see possibly a acinar configuration of these glands. And it exhibited the tumor cells which are lining these acini showed very diffuse and strong positivity with PASD. However, the confirmation came with the utilization of immunostains. And as you can see, this tumor is diffusely positive for trypsin, which clinches the diagnosis of acinar cell carcinoma in this case. One thing I would like to highlight is that acinar cell carcinoma can also show positivity with some neuroendocrine markers, specifically synaptophysin. That's why it can sometimes be confused with neuroendocrine tumors. But it is these characteristic or specific trypsin immunostain that will help you clinch the diagnosis. So acinar carcinomas are rare. Actually, in my practice of over 10 years, I've seen only 3 or 4 cases. It is more common in males, and it can cause hypersecretion of lipase, which can cause hypersecretory syndrome in 10 to 15% of the patients, which is characterized by disseminated fat necrosis, polyarthralgia, and eosinophilia. Typically, acinar cell carcinoma present as large masses, which can undergo cystic degeneration. The prognosis is very poor. And again, as I mentioned earlier, there are specific IHC markers that are very helpful in making the diagnosis of this tumor that includes trypsin, chymotrypsin, and BCL10. So our next case is a 15-year-old boy presenting with abdominal pain. CT scan revealed a cystic lesion of the pancreas. On EUS, a 2.4 centimeter mass was identified, which had a solid and a cystic component, and its appearance on EUS was most suggestive of a cystic pancreatic neuroendocrine tumor. These are the cytological smears, and as you can see over here, it shows a tumor cluster that has a papillary appearance, and on this high power, you can see that very fine vessels are crisscrossing through this tumor cluster. And these vessels are lined by multiple layers of these tumor cells, which are kind of discohesive. In other areas, you can see these tumor clusters, which have this characteristic metachromatic stroma. This is the Pap stain, which highlights the nuclear morphology, which is characterized by presence of these nuclear grooves and very fine chromatin. Also, you will note that some cells have these tail-like projections. These cells are actually called circariform cells. This is a term that was first coined by Dr. Pamuchian, who was actually a cytopathologist in our department and unfortunately passed away a few years ago. This is the classical morphology of the cell block on the cell block that we saw of this tumor, which is characterized by this papillary architecture. But again, the diagnosis of this tumor is highly dependent on immunohistochemical markers. As you can see over here, this tumor exhibited strong diffuse nuclear positivity of beta, catenin, and progesterone receptor, which confirmed the diagnosis of solid pseudopapillary neoplasm. A resection was performed that showed the very typical classic morphology of this tumor. Again, if you look at it, it is characterized by presence of these cleftings, these clefts, and areas of hemorrhage that give rise to the pseudopapillae. And on high power image, you will see a presence of hyalinized vascular cores within the pseudopapillae. This is a cholesterol crystal, and also there is some myxoid stroma. In other areas, you can actually see these pink hyaline intercytoplasmic granules that are typically positive for PAS and are diastase resistant. So solid pseudopapillary neoplasms account for less than 3% of all pancreatic neoplasms, and they are typically seen in young women. Tail is the most common location, but they can occur in extrapancreatic sites, such as mesocolon, retroperitoneum, liver, and duodenum. They are low grade or borderline malignancies, but they can metastasize. And they can also undergo cystic degeneration, as we saw in our case. So this is a table that highlights the cytomorphological and immunohistochemical features of these three tumors: pancreatic neuroendocrine tumor, solid pseudopapillary neoplasm, acinar cell carcinoma. These three tumors can have overlapping features. Although the features highlighted over here, they are very helpful, but I will tell you that it is the immunohistochemical profile of these tumors that is immensely helpful in diagnosis. For example, a solid pseudopapillary neoplasm showed this characteristic positivity with nuclear positivity with beta-catenin, and also positive with progesterone receptor. And acinar cell carcinoma is positive with trypsin, which is extensively used for this to confirm the diagnosis of this tumor. Next, I'm going to present two cases side by side that highlights the prognostic implication of the morphological subtypes included in this rather broad group of tumors. If you look at the history of these cases, one thing is quite obvious. This case 5B, the patient is at a fairly advanced stage with widespread metastasis. And I will tell you upfront that this patient actually passed away within a few months of diagnosis. However, this patient remained alive for more than 5 years. These are the cytological preparations, and over here, this is the Pap stain smear that show a very characteristic feature, as you can see over here, presence of these multinucleated giant cells, which have over 20, 30 nuclei. The background mononuclear tumor cell population show moderate degree of nuclear atypia. However, if you note the morphology of these mononuclear cells, especially the nuclei, they resemble the nuclei of that are within these giant cells. On the other hand, the other tumor is composed of highly pleomorphic or anaplastic looking cells with a lot of nuclear atypia. And occasionally you can identify these giant cells, but these giant cells are very different from these because they have only 2 to 3 nuclei. This is the cell block. As over here, you can see the osteoclast-like giant cell elements, which we saw in this cytology smears. Also, we did see some glandular elements, which at that time we kind of dismissed and ignored. This is the other case, which, as expected, is composed of sheets of these highly anaplastic cells. This is the resection specimen, which actually showed 2 components. One is the component that we already identified in our cytological smears. This is the osteoclast-like component, and the other one is actually a conventional ductal adenocarcinoma. This is the component that we saw over here in the cell block that we ignored at that time. So this is actually an example of an undifferentiated carcinoma with osteoclast-like giant cells. But it also showed a component of conventional ductal adenocarcinoma, a phenomena that has been well documented in the literature. Over here, this is the lymph node, which is showing metastasis by both of these components. This is there is actually an autopsy specimen. The other patient, as I told you, passed away within a few months, and autopsy was performed. And in the pancreas, we identified a tumor, which we already, thought was very anaplastic, and this is actually an undifferentiated anaplastic type of carcinoma. So undifferentiated carcinomas of pancreas include several types. But most important thing, which is actually I demonstrated by showing you these two cases, is to differentiate this first entity, the undifferentiated carcinoma with osteoclast-like giant cells. Because this tumor actually has a way better prognosis than the other subtypes. And as we saw, this can be associated with conventional adenocarcinoma. The other undifferentiated carcinomas have actually overlapping features, and they include anaplastic type, as we saw in our case, the sarcomatoid type, or it could be carcinoma, sarcoma. But it is sometimes difficult to subtype these different types. Again, these types of undifferentiated carcinomas, they carry very poor prognosis, even worse than the conventional ductal adenocarcinoma. And people have done genomic characterization of these tumors, and they've found that almost all of these tumors show KRAS mutations, which means that they probably have some genetic relation to the usual ductal adenocarcinoma, or they are actually a subtype of ductal adenocarcinomas. So our next case is a 64-year-old man with a history of kidney stones, who presented with acute flank pain. And imaging actually revealed pancreatic, tail, adrenal, and right renal mass. On EUS, a round hypoechoic heterogeneous pancreatic tail mass with well-defined borders were identified. And also, there was sonographic evidence of encasement of splenic and artery and the vein. This is the cytological smears. As you can see over here, it is a very cellular specimen, but one feature that is very characteristic of this tumor and very nicely depicted in this image is presence of these transgressing blood vessels that are passing through these tumor cell clusters. And if you look at the tumor cell morphology on this image, you will see that the nuclei are round and eccentric, and in some cells they appear to be about to be extruded from the cells. And over here, if you look at the cytoplasm, they have a wispy cytoplasm, and characteristically they show these very fine vacuolations. So I will say, I will tell you upfront that this is an example of a renal cell carcinoma, a clear cell type. And this is a very characteristic morphology. And as we suspected, our cell block in this case confirms the diagnosis that showed this classical morphology of renal cell carcinoma, which is confirmed by positivity, nuclear positivity of the tumor cells by PAX8. This is a table from one of our studies that illustrate the distribution of pancreatic neoplasms diagnosed by EUSFNA in our institution. As you can see over here, the renal cell carcinomas are by far the most common metastatic tumor types, accounting for 40% of all metastatic tumors in the pancreas, and are even more common than some of the rare primary pancreatic neoplasms, such as solid pseudopapular neoplasm and acinar cell carcinoma. And if you look at the malignancy, they are probably the third most common malignant neoplasm that we encountered. So it is really important whenever you are suspecting a new metastatic tumor in the pancreas to think of renal cell carcinoma. So this is the last case of the first part of my talk. And this is a 69-year-old man with a history of kidney stones. The patient presented to the ER department with flank pain. And on imaging, a renal stone was identified, but along with it, there was also identified was suspicious cluster of enlarged mesenteric lymph nodes. Follow-up PET was performed, which highlighted actually pancreatic and small bowel masses, which on imaging were suspicious for a neuroendocrine tumor. So EUSFNA of this large pancreatic mass was performed, which was actually located in the tail. This is the difficult stained smear. As you can see, it is quite cellular. And even at the low power, you can see that it has a it looks like there are a lot of lymphoid elements in there. And actually, I will tell you, we looked at this. There was a lot of polymorphous population of lymphocytes, and we just called it as, intrapancreatic lymph node or features compatible with an intrapancreatic lymph node. And once we signed out the case, I got a call from the gastroenterologist who told me, Khalid, can you please review this again? Could this be something else? So we went back and we reviewed it, and actually we had missed a lot of clues of actually what actually this is. First of all, if you look at this image, you will see that there are a lot of blood vessels that are coursing through these lymphoid elements. And this is also seen over here in this image. There are a lot of blood vessels, delicate blood vessels that we kind of dismissed initially. And also you will see these purplish clumps. These are actually platelet clumps. And this is the cell block that gave us the diagnosis. And it also shows several clues that you should always keep in mind when you're dealing with this entity. Otherwise, you will miss it. On cell block, two different zones were seen. This is actually the zone which is composed of these back-to-back lymphocytes with some delicate blood vessels. And over here, you see areas of hemorrhage with mixed population, mixed inflammatory cells, although the dominant population is lymphocytes, but you can see a few eosinophils over here, and a few neutrophils. However, the diagnosis was confirmed by using a CD8 stain, which highlights these cells that lines these sinusoids. So this is an example of a intrapancreatic accessory spleen that can just look like lymph nodes. So be aware of this entity. Accessory spleens are actually seen in 10 to 15% of general population. The most common location is actually the hilum of the spleen, but 10 to 20% are located within the pancreas. And on imaging, they can sometimes, look suspicious, or they can mimic some neoplasm of the pancreas because they appear as hypervascular lesions. A very nice review was written by Janani et al. In 2000, where they looked at all the morphological features of intrapancreatic accessory spleens, and they found out that small to medium-sized polymorphic population is almost seen in every case, which is not a big deal. You will see that, but that is not a very helpful feature that you can also see in a lymph node also. Cohesive groups of lymphocytes. But the three features, mixed inflammatory cells, prominent vasculature, and large platelet aggregates are the features that one should always be looking for when you have a suspicion of this entity. The mixed inflammatory cells and prominent vasculature is actually seen in 2/3 of the cases, and large platelet aggregates are seen in about 1/3 of cases. However, the most important or the confirming immunostain is CD8, which highlights the sinusoidal lining cells. Okay, so this is the end of the first part of my talk. Thank you, everybody, for listening, and I will be happy to take any questions. So in this second part of my talk, I will be showing you some interesting cystic lesions of the pancreas. Although most of the cases that I'm going to show you are neoplastic, I've got an interesting non-neoplastic case. Before I start with cases, I want to give you an overview of how pancreatic cystic lesions are managed and how to approach them diagnostically. The diagnosis and management of pancreatic cysts require an interdisciplinary effort to correctly identify the high-risk lesions. Imaging and pathological analysis of the cyst contents are key components in this workup. The low-risk cysts, which includes mostly pseudocysts, serous cyst adenoma, or a lymphoepithelial cyst, are typically followed up and only resected if they are symptomatic or when definitive diagnosis is not possible. High-risk cysts, which mostly includes mucinous cysts, have a high risk of harboring malignancy. And as you can see, the two important mucinous cysts, intraductal mucinous papillary neoplasm, or IPMN, can have up to 30% risk of harboring malignancy, and mucinous cystic neoplasm, or MCN, can harbor malignancy in up to 12% of the cases. Therefore, most of these cases are surgically managed. This illustration shows an algorithmic approach to evaluating cytological samples from pancreatic cyst. So whenever you get a cytology sample from a cyst, the first thing that you need to do is to rule out malignancy. Once malignancy is ruled out, the next step is to see whether you are dealing with a mucinous cyst or not. If you do not see any features that indicate mucinous cyst, then it can possibly be one of these cysts. For example, pseudocyst, which is the most commonly seen cyst, or a serous cyst adenoma, or a lymphoepithelial cyst. And also it could be any neoplastic cyst or a neoplasm that have undergone cystic degeneration. If you identify features that are suggestive of a new mucinous cyst, then the possibilities are either it is an IPMN or a mucinous cystic neoplasm. And as we all know that both these type of cysts cannot be differentiated on cytology. However, one important thing to do once you have identified a mucinous neoplasm is to look for high-grade dysplasia. And whether, and to mention in the report whether there is a presence of high-grade dysplasia or not. The pathological work of pancreatic cysts is not only based on cytomorphological assessment. Cyst fluid tumor markers are integral in risk stratification of pancreatic cyst. One of the most commonly used markers for this purpose is actually carcinoembryonic antigen, or CEA. CEA levels have been shown to increase significantly in mucinous cysts. And at a traditional cutoff of 192, which is almost 200, the diagnostic accuracy of this marker in differentiating mucinous versus non-mucinous cysts is around 80%. However, some recent large-scale studies have questioned the accuracy and utility of this marker in differentiating mucinous and non-mucinous cysts. Therefore, there have been an increasing trend to develop other markers, such as molecular markers for risk stratification of pancreatic cysts. There are a number of studies that have been published on the molecular markers. The most promising ones are mutations in KRAS and GNAS genes. Since these are the two genes which are most commonly mutated in cystic neoplasms. There have been panels that have included other genes such as P53, PIK3CA, and PTEN alterations. However, these alterations are far less common than KRAS and GNAS mutations. And I will tell you from our experience that we rarely send pancreatic cyst fluid for molecular analysis. University of Pittsburgh have been a forefront institution that have developed the molecular panel for pancreatic cyst fluid. But again, it has not gained that traction, and it is not widely used. Our next case, our first case, is actually a 78-year-old man with suspected solid pancreatic neoplasm on EUS, a 3.8 centimeter solid and cystic mass was identified in the pancreatic head with associated duct dilatation, and characteristically, a mucin blob was seen at the ampulla. These are the cytological preparations. As you can see, these are difficult stained smears. First thing to note on this low power magnification are the presence of these papillary structures. On high power, you can see that these papillary structures have very fine blood vessels passing through them. These are the cross sections of these papillary structures. And on low power, you can see that they appear like flower buds. And over here on the high power, you can see the nuclear morphology, which, as you can see, is quite bland. There is very little nuclear atypia. These are additional images. Again, this is a pap stained smear, and it shows this very nice characteristic colored-like thick mucin that is often associated with cystic neoplasms. Over here, you can see the characteristic morphology of the mucinous epithelium, which is, as you can see over here, these are strips of mucinous epithelium with basally oriented nuclei and a long tail indicating the columnar nature of columnar morphology of these cells, which is filled with mucin. This is a very characteristic morphology that you would see again with mucinous neoplasms. This is the cell block that show the cross sections of some of the papillary structures. And over here, you can see that the lining cells are quite bland, and they appear, they have morphological features of gastric foveolar type of epithelium. Again, there's no evidence of high-grade dysplasia. So based on these features, we ended up calling this as features suggestive of interductal papillary mucinous neoplasm with no evidence of high-grade dysplasia. The resection was performed, and as you can see over here, this is an image from that resection specimen. It shows an interductal lesion, which is characterized by formation of these papillary fronds projecting into the lumen. And over here, you see the high-power image, the cross sections of these papillae. These are lined by gastric foveolar type of epithelium. Over here, you can see the very nice the nuclear features, which are characterized by elongated nuclear contours. Most of the nuclei are pencil shape or oval. And also you will see occasional mitotic figures, which are basally located. So this is a typical nuclear morphology of a low-grade dysplasia. As we saw in our cytology specimen, it was an IPMN, which was confirmed on this resection specimen, and there was no evidence of high-grade dysplasia. So interductal papillary mucinous neoplasms, or IPMNs, account for up to 33% of all primary cystic pancreatic neoplasms. They are most commonly seen in elderly males. Most of them, about 80% of these lesions are located in the head. And on endoscopy, a classical feature that we saw in our case also was presence of mucin at the ampulla. IPMNs can be classified based on their location. They can be either a main duct type, branch duct type, or mixed types, or they can also be classified based on the histological features of the epithelium. So they can have epithelium that can be gastric foveolar type, intestinal type, or the pancreatic biliary type. Evaluation of dysplasia is essential whenever you encounter a case. And typically, we follow the two-tier classification. So the dysplasia is either called as low grade or high grade. The low grade encompasses actually the low and the moderate degree of dysplasia, which was included in the previous three-tier scheme that was used earlier. The high-grade dysplasia is essentially reserved for severe or marked dysplasia. Again, separation of IPMN and MCN is not possible on cytology. And also, an important thing to know about these neoplasm is that about 80% of IPMNs harbor KRAS and GNAS mutations. That is why most of the molecular tests that have been employed look for mutations in these two genes specifically. Over here, you can see images from 3 different histological subtypes of IPMN. I will tell you one thing that the histological classification of or subtyping is not essential to report. In my experience, one of the reasons is because you can see all these 3 types of epithelium in a single neoplasm. And also, it is not easy, especially to differentiate sometimes gastric and intestinal type of epithelium, since there are a lot of epithelium that will show hybrid morphology. Anyhow, gastric type of IPMN is the most common type, and it is most commonly associated with the branch type of IPMNs. And again, it is mostly of low-grade variety, as we saw in our case. The intestinal type of IPMN is the second most common. It occurs in IPMN that are of main duct type, and it has an intermediate association with high-grade dysplasia. The pancreaticobiliary type is the one that is almost exclusively or all of the time is associated with high-grade dysplasia. And it is typically seen in IPMNs that are of the main duct type. And one of the characteristic morphological features is shown in this image. As you can see, this pancreaticobiliary type of epithelium will typically show these micropapillae, which can have their apical portion that can fuse and form bridges. And they are typically lined by cells that have more round nuclear contours and high degree of nuclear pleomorphism. So this is an example of high-grade dysplasia. This is from a case where we actually saw high-grade dysplasia in an IPMN. And over here, this is an image that shows a group of mucinous epithelium that has low-grade features versus high-grade features. In the low-grade, you can see that the epithelial cells have more abundant cytoplasm and rather smaller nuclei. These are the high-grade cells that characteristically show nuclear enlargement and a high NC ratio, which is one of the most important features to note when you are evaluating high-grade dysplasia in mucinous neoplasms. This is a paper that came out initially where they looked at the differentiating features of low-grade and high-grade mucinous epitheliums in IPMN. And it is published by Dr. Pittman, who is a well-known figure in pancreatic cytology from Mass General Hospital. So in their paper, they found out that the 3 features that are highly associated with high-grade epithelium include increased NC ratio, which is actually has an accuracy of over 80%. Chromatin pattern changes, which can be either hypochromasia or hyperchromasia, and that is was seen in almost 85% of their high-grade cases. And at the end, background necrosis, which, if present, is again highly associated with high-grade IPMN epithelium. IPMNs can also be associated, or they have a significant high risk of association with malignant neoplasms. One of the neoplasms that is exclusively seen in IPMN is actually choroid carcinoma. It typically arises from IPMN that harbors intestinal type of epithelium. Important thing to note about this tumor is that it has a far better prognosis than the conventional ductal adenocarcinoma. And it is characterized by presence of these invasive mucin pools, as you can see over here, which characteristically show these mucinous epithelial strips floating within this mucin. This is a very, again, classical morphology of coloid carcinoma. Ductal adenocarcinomas are actually more commonly seen in association with IPMNs. The literature in this regard is conflicting. There have been various numbers. Some actually studies have shown much higher numbers of ductal adenocarcinomas associated with IPMNs. However, there is a recent study that came out of Emory that was published in this year, earlier this year, and it had over 500 cases where they looked at ductal adenocarcinomas and presence of IPMN, and they found that about 5% of ductal adenocarcinomas have had IPMNs associated with it. And if you include mucinous cystic neoplasms or MCNs, the number increases 6.2%. And most of their IPMNs had this pancreatic biliary type of epithelium. Our case 2, which is a 67-year-old woman with incidentally found pancreatic tail cyst. The initial EUSFNA that was performed at an outside hospital actually showed a low CEA and a benign cytology. Repeat EUS were performed at our hospital, and it showed a thick-walled cyst measuring about 2.4 centimeters in greatest dimension. The cystic region of the cyst was aspirated, yielding about 7 mils of non-viscous fluid with debris. And cyst fluid chemistry was done that showed very high CEA levels of almost 4,000. These are the cytological smears. This is a Diffquith stain smear. As you can see over here, there are two type of cell clusters. Over here, this is a epithelial group that has quite bland morphology. And this is another epithelial group that is showing significant atypia. Similarly, in this pap stained smear, you can see the honeycomb nature of this bland epithelial groups versus this epithelial group that is showing significant cytological atypia. Another image from that atypical appearing group, as you can see over here, it is showing this characteristic two-tone cytoplasm, which is to some extent similar to what you see in pap smears that has radiation change, that show radiation change actually. However, if you look at the nuclear features, the nuclei are have kind of smooth outlines. There's some nuclear size variation, but overall, the impression that we get from this morphology is that it is more reactive looking rather than neoplastic. Also associated with this epithelium, we saw a few giant cells. This is a cell block that shows a few of those atypical cells that we saw on the cytological smears. In addition to that, we saw strips of these really bland appearing cuboidal epithelial cells that stained positive for CK7. So at the end, based on that cytological atypia that we saw in some of the cells, we ended up calling it atypical. And the patient underwent resection because there were a lot of atypical features or a lot of concerning features that were seen on imaging, and also, the cyst fluid CEA levels were also increased. This is a resection specimen. Couple of things to note over here. First, if you look at the lining epithelium, you will see over here that it is denuded. There's no epithelium in this area. Over here, you see an epithelium that has multiple layers, have some reactive look. And then over here, you will see the single layer cuboidal epithelium that we also saw on our cytology smears. However, the most important clue in the diagnosis is over here, which is the stroma that is characteristically is showing that bluish discoloration and is quite characteristic of this entity. These are the high power images of the dissection specimen. Over here, you can see that the cyst is lined by these cuboidal epithelial cells that are rather bland. Over here, you see multiple layers of cells. And this is the epithelium that actually was giving us that atypical features. And over here, you see that the stroma of this cyst is actually staining very nicely with estrogen receptors, which gives the diagnosis of mucinous cystic neoplasm. So this was a very interesting case because as we are taught and as we expect to see mucinous epithelium in MCNs, this case did not show any evidence of mucinous epithelium. Most of the epithelium that we saw was either this reactive type or cuboidal. However, it is the stroma that characteristically displayed, had features of ovarian type stroma, and it showed positivity with ER that was good enough for us to make a diagnosis of MCN on this case. Mucinous cystic neoplasms, they account for 8% of all primary cystic neoplasms of pancreas. They are seen exclusively in females, although I will tell you that we have seen a few cases that have happened in males. They are mostly located, or greater than 90% are located in the tail, and they are typically multiloculated and do not show any connection to the pancreatic ducts. Again, MCNs are high-risk cysts because they have up to 12% chances or risk of harboring malignancy. The cyst lining is classically a mucinous or a biliary type, as you see over here. This is the more classic morphology of an MCN showing this mucinous lining. And over here, you can see the biliary epithelium. And this characteristic ovarian-like stroma, which is essential in diagnosis of this entity. This stroma is typically positive for progesterone receptor, estrogen receptor, inhibin, and calretinin. MCNs can also have mutations, and the most common mutations are the KRAS mutations that can be seen in up to 75% of the cases. I would just like to take a few minutes to discuss the epithelial linings that is associated with MCN. This is how we, again, typically, we are taught that MCN will have a mucinous lining. And this is what we are looking for when we are trying to diagnose this entity. However, this is a paper that was published a few years ago, and it came out of Emory, where they looked at 136 MCNs, both from pancreas and from liver. And if you note over here, 1/4 of their cases had 90 to 100% of epithelium that was non-mucinous, which is a very, very important thing to note. So whenever you are encountering or whenever you're thinking of MCN, also make a note that they will not always show mucinous epithelium, and a significant portion of these neoplasms can actually have non-mucinous epithelium. Our next case is a 79-year-old man with enhancing pancreatic head mass that was picked up on a surveillance CT scan after the patient was resected for a clear cell renal cell carcinoma. On EUS, a 1.3 centimeter discrete round mass was identified with difficulty, and it did not show any evidence of cystic change. So these are the cytological smears. Given the history, this is a case that I saw. When I looked at it, I said, oh, this is most likely going to be a renal cell carcinoma. It is showing these cells, as you see over here, with kind of clear cytoplasm and round, very mildly dysplastic nuclei. It has some pseudoecinar formations over here. And if you look at this diff-quick stain, you will see that some of these cells, they resemble the cells of the case I showed you in my first part of metastatic renal cell carcinoma. They have kind of a wispy cytoplasm. However, the characteristic microvaculations that are associated with renal cell carcinoma were absent. This is the cell block that showed these back-to-back glands lined by somewhat clear cells. At that time, I only ordered a PAX8 stain. I was quite sure that this is going to be metastatic renal cell carcinoma, but to my surprise, it came back negative. As you can see, that there's no nuclear positivity with cells with PAX8. On this high power, again, the cells have a rather round, bland nuclei and clear cytoplasm. Then we further did some additional histochemical and immunostains. And at that time, I thought out of the box and and brought some additional entities in the differential diagnosis. And actually, I thought probably this might be a serous cyst adenoma because of the clear cytoplasm that we saw on cytological preparation. Again, very nicely, you can see that these epithelial cells are very strongly positive for PAS. And this positive staining is washed away by diastase treatment, which kind of clinches the diagnosis of this entity. And this is inhibin, which can be seen, which is typically, you expect to see a lot more positive cells, but in this case of our serous cyst adenoma, we saw only very few cells that were staining positive for inhibin, but still they were positive cells. So this was a very unusual variant of serous cyst adenoma, which is the solid variant, and that can be mistaken for other, neoplasms of the pancreas, such as neuroendocrine tumors. And in this case, our clinicians were highly suspected and suspicious of this being a metastatic renal cell carcinoma. So serous cyst adenomas actually account for 16% of all primary pancreatic cystic neoplasms. They are most commonly seen in elderly females. Most of them are located in the body and the tail. They have a characteristic radiological appearance with the central scar and the sunburst pattern of microcalcification. They are typically well circumscribed and multilocular, and that's why they give a soap bubble appearance. On gross examination, they have a very characteristic cut surface, which appears sponge-like. And again, if you have seen one, you will not forget. The cells, they are, they have clear cytoplasm, which is rich in glycogen, and that is why it is positive for PAS and washed away by PAS with diastase. You can utilize certain immunostains such as inhibin and MUX6, but I would say that it is the morphology and the staining pattern with PAS and PST that will give you the diagnosis. So next I'm going to present a pair of cases that highlights the importance of adequate sampling and knowing the atypical presentation of some common lesions that are encountered in the pancreas. As you can see over here, both of these patients presented with cystic lesions. However, in this patient 4A, only the cyst fluid was aspirated and the wall of the cyst was not sampled. In the second case, not only the cyst fluid was aspirated, but the wall was also sampled. So this is the first case this is the cyst fluid cytology that is actually showing a lot of cellular debris in the background. There were a few cells that were seen where you can see the degenerative changes in the nuclei. Over here also, this is a mucicarmine, which we typically do mucicarmine stain in all of our cyst fluids. Mucicarmine is totally negative, but it highlights some of these cells that have degenerative nuclear changes. At that time, we just totally ignored these cells and we called it negative. So in this case, this is actually an example of a case where, as I mentioned to you earlier on, that workup of pancreatic cysts is multidisciplinary. In this case, the cyst fluid was negative. The cyst fluid tumor markers were also low. However, on follow-up, the imaging was a little bit concerning. So our clinicians, they felt that this might be more than benign. And they actually, based on the imaging features, they decided to go with surgery. And this is the resection specimen that we received, which clearly show a very nice neuroendocrine neoplasm that have undergone cystic change. You can see the cyst wall over here, and on high power, you can see that these neuroendocrine cells, they are kind of exfoliating from the cyst wall into the cyst fluid, and their nuclear morphology is different from the cells that are within the wall. They are more dark and are undergoing degenerative changes. These are the cells actually that we saw in the cyst fluid. You can see over here. Again, it was confirmed that this is a neuroendocrine tumor by a very nice and diffuse positively with chromogranin. In the second case, actually the cyst fluid yielded, it was more cellular, and it has cells that had much better preserved nuclear morphology, which gives you a hint of neuroendocrine type of chromatin, with salt and pepper type of chromatin. So we call this atypical cells with features suggestive of a neuroendocrine tumor on the cyst fluid. But the cyst wall sampling actually was the one that made the diagnosis possible. And as you can see over here, it is showing the classical features of a neuroendocrine tumor, a well-differentiated neuroendocrine tumor, with this cells with plasmacytoid morphology, bland, very monotonous appearing nuclei, and the tumor cells are showing diffuse positivity with chromogranin, and on Ki67, the proliferation index is less than 2%, which is consistent with the diagnosis of a well-differentiated neuroendocrine tumor. Cystic changes in pancreatic neuroendocrine tumors is actually not that rare. And there have been many studies published, and it has been shown that up to 17% of these tumors can undergo cystic change. And since CEA and amylase are non-contributory, lack of awareness of this atypical presentation of pancreatic neuroendocrine tumors may result in inadequate sampling, and it increases the likelihood of the sample to be read as benign, as happened in the first case that I showed you, where the cyst wall was not sampled. So whenever you are evaluating cyst fluid, it is important to keep the possibility of cystic change in a neuroendocrine tumor. This is the last case. This is a 59-year-old woman with complex history, and on workup, she was found to have a 6.3 centimeter cyst near the tail of the pancreas. MRI showed that it's a complex cystic structure. The patient came from an outside hospital where 2 prior attempts of sampling the cyst via EUSFNA they were made, but there was no definitive diagnosis. The patient came to us where a 7.6 centimeter complex cystic structure was identified, and it was located between the tail of the pancreas and the spleen. And it had a 1.9 centimeter solid lesion in the wall. However, the most concerning thing was that the cyst fluid chemistry showed a CEA levels of greater than 10,000, which was highly concerning. These are the cytological images from the cytological smears. And over here in this image, if you see a couple of things that you will note. First, there is presence of some lymphoid elements in the background, along with these cellular debris. However, you cannot make out the type of epithelium that is seen over here. This is an epithelial group, again, which is too dark to give you any morphological characterization of the type of epithelium. Over here, we also saw within the debris some crystals that had that has a square morphology. Over here, these are more well-preserved epithelial groups that again on this difficult stain, although appear more benign looking, they are more benign looking, but again, it is hard to identify them as squamous or glandular. This is the pap stain, which actually is showing a morphology that is more in tune with the squamous epithelium. However, it is not exactly certain whether this is a squamous epithelium. It was actually the cell block that was essential in making the diagnosis in this case. And as you can see over here, it is showing the classical morphology of the lymphoepithelial cyst, which is characterized by this multiple layer of squamous epithelium with underlying lymphoid elements. And you can see a fragment of lymphoid element over here. There might be a little bit of focal atypia in the squamous epithelium. We also found some keratin debris, anucleated squames that were not readily identifiable on the smears. So this is a very comprehensive study that actually was published a few years ago. It came out of John Hopkins group. And the authors over here presented clinical pathological data from 29 of their own institutional cases of lymphoepithelial cyst, and also reviewed various other studies with additional 185 cases of lymphoepithelial cyst. So their total cohort was over 200 cases. And these are some of the findings that they came up with. So one of the things that they noted is that most of these lymphoepithelial cysts are misdiagnosed as cystic neoplasms. And another finding that they mentioned and they pointed out is that these cysts, they have a very characteristic imaging pattern that is seen on radiology, which is something that we also saw in our case, and that is the exophytic pattern of growth. In our case, if you look at the history, this cyst was present in between the pancreatic tail and the spleen, so rather than intrapancreatic. So this is an important radiological finding that they have mentioned that is associated with lymphoepithelial cysts. Also, they noted that the cyst fluid tumor markers such as CEA and CA19-9 are elevated in many cases, in their series up to 50% of the cases. And this is also something we noted in our case, where actually CEA levels were greater than 10,000. And that was something that was bothering our clinicians a lot. Actually, the case that I showed you, the patient went to an outside hospital where the resection of the cyst was performed, and it was indeed a lymphoepithelial cyst. In their paper, they also talked about in detail the cytological features, and they specifically mentioned that it is less than 50% of the cases where you will see the classical features of a lymphoepithelial cyst, such as squamous epithelium with keratin debris, lymphoid elements and the cholesterol, the square cholesterol crystals that we saw in our case, which corresponds to the accuracy of diagnosing the cyst, which is only in 40% of cases. Therefore, it is important to know the clinical, radiological, and cytomorphological features of lymphoepithelial cyst, because if you know how these cysts can show up on radiology and on cytology, that can lead to improved diagnosis and can prevent unnecessary surgery in these cases. With this, I will end my presentation. Thank you again for listening, and I will be happy to answer any questions.
Okay, thank you very much, Dr. Khalid, for these magnificent lectures on pancreatic pathology. And now this is time for question and answers. Any question from the audience? I think they have understood each and everything, I think. So, any difficult question? Dr. Zainab actually wanted to ask a question.
Can you hear me?
Yeah, absolutely.
Okay.
Now, this is a question for you from Dr. Zainab.
Assalamu alaikum, sir.
Walaikum salam.
So we saw that the undifferentiated carcinomas with osteoclast-like giant cells, they were associated with conventional adenocarcinomas. Is there
Yes.
a particular percentage of the undifferentiated component to render this diagnosis, or any percentage will upstage the tumor to undifferentiated carcinoma with osteoclast-like giant cells?
No, there's no percentage. If you see the component, typically, so these cases are quite rare, I would say. And the osteoclast, like giant cell component, will be the dominant component. Again, I will tell you, this tumor behaves very differently from even the conventional ductal adenocarcinoma. And the case that I presented, actually, the patient lived for more than 5 years. So it is, although there are not that many cases that have been reported, but a lot of literature is coming about this rather rare entity, although it is not as rare as we thought. And all of them are showing that this has a much better prognosis. So that is why it is separated from the other undifferentiated tumors. And it is essential that you convey this information to the clinicians, because they are highly responsive to therapy, and the patients have a much better prognosis.
Okay, now next question is, sir, because these are associated with conventional adenocarcinomas, can we assume, or is there any literature that points to the fact that conventional adenocarcinomas may progress to undifferentiated carcinomas with osteoclast-like giant cells?
Actually, it is differentiation. As I told you, many papers have come where they've done genomic characterization of these tumors, and if they have found that most of these undifferentiated carcinomas have KRAS mutations, which are the mutations that are found in the conventional ductal adenocarcinoma. So probably it is just a matter of differentiation. These tumors, when they start, they differentiate into two different, lines, that's how they kind of progress.
Okay, and my last question is that the pancreaticobiliary tract is subject to a lot of conditions that causes reactivity and cytological smears.
Yep.
So in your expert opinion and experience, how do you differentiate between low-grade dysplasia and reactivity? Or rather, I should rephrase that. What are the factors that you utilize to come to a diagnosis in these cases?
A very nice question. And if I can answer this question, I will be the #1 cytopathologist. That is, This is one of the most difficult thing, well-differentiated adenocarcinoma versus reactive atypia. There's no magic bullet, let me tell you. That is why I showed you a table from one of the earlier studies that looked at various features. You have to weigh various features. One of the features that I find highly valuable, and which has been also mentioned in the literature, is anisonucleosis. And we also teach our trainees, you have to look for 1 to 4, the nuclear size variation. So that is one feature you look for. And again, it is culmination of many factors. I mean, adequate sampling is the key. And there will be cases, and you'll see cases where you will not be able to call them malignant. You will call them atypical or suspicious. The patient will come back, with repeat sampling. In most of the cases, what I've seen is that you will find a tumor. But again, there are, a few cases of very profound atypia, reactive atypia in context of chronic pancreatitis, which is extremely difficult.
Thank you, sir.
Okay, now the question from Dr. Sajid Mushtaq.
Well, it's wonderful lecture. Very informative. I want to ask a question about mixed neuroendocrine, non-neuroendocrine. The percentage, 30%, is it based on histology alone or applies to the cytology as well?
No, it is only on histology. As I showed you.
But in cytology, if you see both components, you will think of mixed neuroendocrine.
Yes, absolutely. We have seen a few cases, and once we see both of these components, we will call it malignant neoplasm, and we will, put in a comment or something that this could be a mixed, this could be a menin, but actual diagnosis of menin is on histology, because it has a specific criteria as mentioned in the recent WHO publication, that each component has to be 30%.
Thank you.
So is there any other question? I think your description was so detailed and so looking easy that everybody has understood each and everything.
Thank you. I'm really honored to present at this, at the symposium, and I will thank you, and also thank my mentor, Dr. Sajid Mushtaq, who was the one who actually trained me. So it is great to be here.
Thank you very much. We are all honored of your presence here, and for your time and for your lectures. And I think this would be, the next time, this would be a physical presence the next year.
Inshallah.
Okay, thank you very much. Thank you.
Thank you.
So for the start of our next session, we have 15 minutes. Okay, and your presence is definitely required after 15 minutes.